Good evening. Good evening, all. I'm Dr. Anuja, doing my family medicine DNB in Medical Trust Hospital. My case is titled as Not So Sweet, a Diagnostic Masquerade. So, I'll be presenting a case of 34-year-old female who is a homemaker and she is from Ambunad, Ernakulam. Patient is a known case of type 2 DM, but she's not taking any regular medicines for the same. Patient was apparently normal till 22nd of December 2025. Suddenly, she presented with complaints of acute onset, high-grade fever associated with severe myalgia, arthralgia, and bilateral lower limb edema. She initially visited a local hospital, took some antibiotics, oral antibiotics, but as there was no symptomatic relief, she got admitted in a local hospital on 24th of December 2025, where she was treated with injection piperacillin tazobactam and IV injection doxycycline. She was febrile during the course of stay, where she was managed with IV paracetamol and all. On 25th of December 2025 evening, there was sudden onset multiple tender papules over the lower extremities and trunk. It was also noted the CRP increased from 71 to 141 mg per liter. For further evaluation, patient was referred to Medical Trust Hospital and she got admitted in our hospital on 26th of December 2025. On admission, patient was conscious, oriented, vitals were all stable. Sugars, GRBS was 221. Systemic examination was also normal. There was no redness of the eyes or dryness or joints, or there was no deformities or no synovitis also was noted. Dermatologic examination, there was multiple tender erythematous to violaceous papulonodular lesions measuring around 2 to 3 centimeters distributed over bilateral lower limbs, trunk, back of the neck. A bilateral lower limb pitting edema was also noted. There was no other patches or plaques noted in the patient. At this point, our differentials included a sweet syndrome or erythema nodosum associated with systemic infections like TB, streptococci, or granulomatous infections like sarcoidosis, or considering an age, female patient in a reproductive age group, SLE was also considered. Basic investigations, CRP was 197. Total count was 11,000 at the time of admissions, which subsequently increased to 17,000 on the next day. Neutrophil was 80.2%, which also increased to 90.9%. Lymphocytes was 17%. Hemoglobin was 11.7 gram per deciliter. Platelets was 184,000. HbA1c was elevated, 10.4%. TSH was 2.48. Urine routine showed glucose 3+, ketone body 1+, pus cells of 4 to 5 cells per high power field. Leukocyte esterase was negative. RBCs were 17 to 18 cells were present. There was no bacteria or no cast in the urine. LFT and RFT was within normal limits. So, as a further workup were done, a peripheral smear showed normocytic pneumochromic anemia and mild neutrophilic leukocytosis. USG abdomen, USG breast was also normal. Echo was done, which also came within normal limits. Valves were all normal. TB quantiferon was tested as we suspected as our differential had a suspicion of DB, so TB quantiferon was also tested negative. Blood and urine cultures were sterile. ANA, anti-dsDNA, C3, C4 levels, ASO titer were also tested negative. All tumor markers also tested, which was also negative. In our hospital course, she was started with IV meropenem, insulin therapy for her glycemic control, and dermat consultation was sought, and sweet syndrome impression was initially made. For diagnosis, for confirmation, a skin biopsy was obtained and sent for analysis. Oral steroids, that's Vislon, was initiated at 0.5 mg per kg and was tapered by 5 mg over every 3 days in view of severe hyperglycemia. So, why sweet syndrome was considered in the first place is because it was fitting into the diagnostic criteria of sweet syndrome. There was abrupt onset of painful eruptive plaques and nodules. Patient was febrile. Lab parameters were also fitting into the criteria of sweet syndrome, and there was also a very good response to the steroids. Patient was during the course she improved very well. She became febrile. Lesions resolved. Edema also decreased. She was discharged on Vislon and basal bolus insulin, and she was advised to come back after 10 days with the biopsy report. So patient came to the OPD after 10 days with the biopsy report, and her biopsy revealed small to medium vessel vasculitis, neutrophilic infiltration, fibrin deposition, moderate leukocytoclasia, and granuloma formation. So the impression was made as granulomatous vasculitis, and the differentials include erythema nodosum leprosum and vaginous granulomatosis. So C ANCA and P ANCA was at that time was tested and was tested negative. For the erythema nodosum leprosum part, skin slit smear was sent. To our surprise, it came a positive, and the right earlobe smear tested bacteriological index of 1 and morphological index of 10%. So the final diagnosis came as erythema nodosum leprosum type 2 lepra reaction, presenting as sweet syndrome-like reaction, previously undiagnosed multibacillary leprosy, and uncontrolled type 2 DM. So this highlights that ENL can be the first or predominant manifestation in a patient who has underlying multibacillary leprosy with with absence of overt clinical symptoms like a hypopigmented patch or a thickened nerves. So in overview, leprosy is a chronic infectious disease caused by Mycobacterium leprae. Despite it being a very treatable and preventable disease, cases still occurs in more than 120 countries, with around 2 lakh new cases reported every year. The majority of annual new cases are detected from the Southeast Asia region, contributing to 72% according to the epidemiological records of WHO. In coming to India, we have a very good national leprosy eradication program. The program has drastically reduced the prevalence rate of leprosy during the past decades, and these are the objectives of the aims of the leprosy eradication program. To highlight prevalence rate to the objective is to reduce the prevalence rate to less than 1 per 10,000 population. The current situation in India is, according to the 2024 to 2024 records, a total of 1,957 new cases were detected, resulting in an annual detection rate of 7 per 1 lakh population. 82,297 leprosy cases remain undertreated. A total of 1,892 new leprosy cases with type 2 disability, grade 2 disability, and a total of 4,722 child cases were recorded. The diagnosis of leprosy, there will be a definite loss of sensation in a hypopigmented or a reddish skin patch, thickened or enlarged peripheral nerves with loss of sensation or weakness of the muscles applied by the nerves, presence of acid pass bacilli in the skin slit smear. Leprosy is a highly variable disease affecting different people in different ways according to their immune status. Everyone will be familiar with the Ridley-Joplin classification, which ranges from TT to LL. As we move from TT to LL, the bacillary load increases, the number of lesions increases, the lesions become more symmetrical, and the cell immunity decreases. As per WHO, we have two classification, paucibacillary and multibacillary. Paucibacillary is 1 to 5 skin lesions without demonstrated presence of bacilli in a skin smear. Multibacillary is more than 5 lesions or with a nerve involvement or with a demonstrated presence of bacilli in a skin slit smear, irrespective of number of lesions. So our patient will be in a multibacillary, will come under multibacillary classification because she had no skin lesions or no nerve thickening and all. She just had bacilli in her skin slit smear. Coming to the management part, it's not just the chemotherapy. You have to treat the reactions, reduce the risk of nerve damage, educate the patient to cope with the existing nerve damage, treat the complications of nerve damage, and rehabilitate the patient socially and psychologically. Treatment part, possibacillary, 6 months courses duration is the treatment duration, and multibacillary 12 months is the duration of treatment. You can use dapsone, clofazimine, and rifampicin. These are the doses. Lepra reactions, we have two types of lepra reaction, 1 and 2. One is immunological response to presence of mycobacterial lepra antigen, which is a type 4 hypersensitivity reaction. We see there will be acute inflammation of existing lesion, whereas in type 2 lepra reaction, which is acute inflammatory response to immune complex deposition, type 3 hypersensitivity reaction, new lesions will be formed in new painful erythematous nodules will be formed in ENL. The neuritis part will be the nerve tenderness will all be more prominent in type 1 lepra reaction, and systemic involvement will be more in type 2 lepra reaction. We can, if there is only mild ENL, we can treat it with analgesics and NSAIDs. If it's severe, prednisolone, thalidomide can be used.
Thank you, Anuja. So, this case was actually referred by our own Hashik. Hashik had referred this case. We are so used to getting excellent referrals over long weekends and special leave. So this actually happened on Christmas Eve, and luckily I was coming back post Christmas 26th, and Hashik called me up and said, "Sir, I need some help. There is a patient like this." So to be very frank, we were also almost 100% sure it was only sweet syndrome, but as we always say, always microbiologically analyze all your specimens, and all your specimens have to be sent for microbiological analysis, come what may. So our dermatologist was also in for a shock, and she called me up and said there is something like this, and we usually send across to Kopiker's Center for Dermatopathology. And when the results came, we had only two options: either you work up for ANCA vasculitis or lepra reaction. But I grew up in Chalakudy, so if you remember the road to Chalakudy, just before the Chalakudy bridge, there's a left side, just after the Divine Retreat Center, there's an outskirt which I know Raj sir and all will remember. There used to be a Kushtaroga colony. You remember? അപ്പോൾ അവിടെ ഞങ്ങളൊക്കെ ചെറുപ്പത്തിൽ when we used to go for college and school and all, നമ്മൾ അങ്ങോട്ട് നോക്കത്തേ ഇല്ല, because we were that scared of leprosy. In fact, I remember one of my classmates actually had an Om t-shirt, Rudrakshmala and all that. Anish will know who that we are talking about. His mother's biggest punishment was that she distributed all his Django t-shirts to the lepers who used to come home. So, what I meant to say was it was a social stigma. People used to ostracize these people, keep them away from sight, and even when they come, they used to come with a bell, So it's not that rare. We should keep this also at the back of our mind. And this lady is from a upper middle class family. I think the only risk factor that I can imagine is extremely poorly controlled sugars. In fact, when our dermatologist suggested 1 mg per kg, I said, please, if she has to go home, she was already on basal bolus, and to add steroids on top of it was going to be very difficult. She is doing very well. She has actually been referred to leprosy eradication centers only because we had difficulty in procuring the drugs. She's on very good follow-up. Her sugars are well controlled. And even when she was leaving, her husband was telling me, please tell her to take the medicines regularly. So a wake-up call for most of us. In fact, I have not seen this kind of a presentation for leprosy. I would invite comments from senior colleagues who would have seen more leprosy than many of us, as at least in our 4th or 5th decade. Raj sir, your experience, please.
ഞാൻ മലയാളത്തിൽ പറയാണ്. ഇപ്പോൾ ഈ കേസ് പ്രസന്റ് ചെയ്ത് വളരെ നല്ലൊരു പ്രസന്റേഷൻ ആയിരുന്നു. പക്ഷെ ഇത് ഇപ്പോൾ വളരെ അൺകോമൺ ആണ്, അതുകൊണ്ടാണ് ഇത് മിസ് ചെയ്തു പോകുന്നത്. എന്നാൽ ഞാൻ പഠിക്കുന്ന കാലത്ത് ലെപ്രസി എന്ന് പറഞ്ഞാൽ വളരെ വളരെ കോമൺ ആണ്, വളരെ കോമൺ ഡയഗ്നോസ് ആണ്, വളരെ ഈസി ഡയഗ്നോസ് ആണ്. ഈ ടെസ്റ്റുകളൊന്നും ഇല്ല. സാധാരണ നമ്മൾ ക്ലിനിക്കൽ ഡയഗ്നോസിസ് ഓൺലി ബൈ ഒബ്സർവേഷൻ ആൻഡ് ബൈ clinical examination, we come to a diagnosis, then you do the slit
Slit
exam
skin.
on the earlobe.
Earlobe.
That ഈ പറഞ്ഞ ഒരു ടെസ്റ്റും ഇല്ല. ഈ ENL കേസിനെ പറ്റി പറയുകയാണെങ്കിൽ വലിയ റിസൾട്ട് വെച്ചാൽ ഞങ്ങൾ മെഡിക്കൽ കോളേജിൽ നിന്ന് അങ്ങനെ ലെപ്രസി പേഷ്യൻസ് അറിഞ്ഞുകൊണ്ട് വരാറില്ല. കാരണം ലെപ്രസിക്കല്ല അന്ന് നൂറിനാട് കൃഷ്ണ ആശുപത്രി ഈ കൊരട്ടി പറഞ്ഞ കൊരട്ടിയൊക്കെയാണ് പൊയ്ക്കൊണ്ടിരിക്കുന്നത്, ചേവായൂരും. പക്ഷെ അറിഞ്ഞുകൊണ്ട് വരാൻ അറിയാതെ ഒരുപാട് കേസ് സ്കിൻ എന്നൊക്കെ പറഞ്ഞ് വരും. ഈ ENL കേസിന് ഞാൻ പറയാൻ കാരണം വെച്ചാൽ ഞങ്ങളുടെ മെഡിസിൻ ഡിപ്പാർട്ട്മെന്റ് കൃഷ്ണദാസ് സാറിന്റെ യൂണിറ്റിൽ ഇതുപോലെ ഒരു കേസ് വന്നു. അപ്പൊ ഈ കേസിന് സാറ് അപ്പടെ ഒരു കൺഫ്യൂഷനിലായിരുന്നു. സാറിന് ഇങ്ങനെ ഡയഗ്നോസേ പോയില്ല. അപ്പൊ ഞങ്ങൾ PGs ആണ് സാറേ ഇത് കുഡ് ബി ENL എന്ന് പറഞ്ഞു. സാറപ്പം ഇത് കേട്ടിട്ട് പേഷ്യന്റ് മുമ്പ് വെച്ച് പെട്ടെന്ന് അങ്ങ് വണ്ടറായിപ്പോയി. കാരണം സാർ അതുവരെ ചിന്തിച്ചിട്ടില്ലായിരുന്നു. എന്നിട്ട് ആ കേസ് ഏകദേശം 50 വർഷം മുമ്പ് ഞാൻ ക്ലിനിക്കിൽ പ്രസന്റ് ചെയ്യുകയും ചെയ്തു. അവിടുത്തെ ട്രിവാൻഡ്രം മെഡിക്കൽ കോളേജിലെ ക്ലിനിക്കിൽ പോയി പ്രസന്റ് ചെയ്യുകയും ചെയ്തു ENL. ഇനി അത് കഴിഞ്ഞിട്ട് ഞാൻ സർവീസ് കയറിയപ്പോഴും എല്ലാ താലൂക്ക് ആശുപത്രികളിലും SCT സെന്റർ എന്ന് പറയുന്നുണ്ട്, സർവേ എറാഡിക്കേഷൻ ആൻഡ് ട്രീറ്റ്മെന്റ് സെന്റർ എന്ന് പറഞ്ഞാൽ അവിടെ ഈ ലെപ്രസി ഹെൽത്ത് വിസിറ്റർ കമ്പൽസറി ആയിട്ട് എല്ലാ ഹോസ്പിറ്റലും ഉണ്ട്. അവർ ആ താലൂക്ക് ഹോസ്പിറ്റലിന്റെ ഏരിയയിലുള്ള സ്ഥലത്ത് പോയി വീടുകളിൽ പോയിട്ട് ഒരു ദിവസം ഇത്ര വീടുകൾ കാരണം നോക്കി കണ്ടുപിടിച്ചു കൊണ്ടുവരും. ഞങ്ങൾ ഇഷ്ടംപോലെ കേസുകൾ ലെപ്രസി ഞങ്ങൾ ഒപ്പിരുന്ന് കാണുമായിരുന്നു. ഈസി ആയിട്ട് ട്രീറ്റ് ചെയ്യുകയും ചെയ്യും. കാരണം അത് മരുന്നൊക്കെ അവൈലബിൾ ആണ്. ബാക്കി ഏത് മരുന്നില്ലെങ്കിലും ലെപ്രസിക്കും TBക്കും ഉള്ള മരുന്നുകൾ ഗവൺമെന്റ് ഹോസ്പിറ്റലിൽ അവൈലബിൾ ആയിരുന്നു. ഒരുപാട് ട്രീറ്റ് ചെയ്തിട്ടുണ്ട്. എന്നാൽ ഈ കഴിഞ്ഞ 23 കൊല്ലമായിട്ട് ഞാനിപ്പോൾ ഒരു പ്രൈവറ്റ് ഹോസ്പിറ്റൽ വർക്ക് ചെയ്യാണ്. 23 കൊല്ലത്തേക്ക് 2 കേസ് ഞാൻ ലെപ്രസി ഡയഗ്നോസ് ചെയ്തിട്ടുണ്ട്. ENL അല്ല, ലെപ്രസി.
അത് സാറി പറയുന്നത് സ്കിൻ ലീഷൻസ് ആൻഡ് നെർവ് ഫൈൻഡിങ്സ് ഉള്ളത്.
നമ്മുടെ സാധാരണ
ഹൈപ്പോപിഗ്മെന്റഡ് പാച്ചസ് ആൻഡ് തിക്കൻ നെർവ്സ്.
ട്യൂബർക്കുലോയിഡ്, ലെപ്രമാറ്റസ് അല്ല, ട്യൂബർക്കുലോയിഡ് ആണ്. പേഷ്യന്റ് കംസ് വിത്ത് പാച്ച്. നമ്മൾ ടെസ്റ്റ് ചെയ്ത് നോക്കുമ്പോഴത്തേക്ക് ടച്ച്, പിന്നെ ഹീറ്റ് സെൻസേഷൻ കുറയും, നെർവ് തിക്കനിങ് ആണ്. ഞാൻ ഈ പേഷ്യന്റ് നമ്മൾ ട്രീറ്റ് ചെയ്തിട്ടില്ല. അപ്പം തന്നെ നമ്മൾ ഇവിടെ എറണാകുളം ജനറൽ ഹോസ്പിറ്റലിലെ TB സെന്റർ അവിടെ മാത്രമേ ഉള്ളെന്ന് പറഞ്ഞു അവിടോട്ട് റെഫർ ചെയ്തു. അല്ല, ലെപ്രസി സെന്ററിലേക്ക്. ഇന്നത്തെ കാര്യം എനിക്കറിയില്ല. 2 പേഷ്യനെ കറക്റ്റ് ഡയഗ്നോസ് ചെയ്തിട്ടുണ്ട്. ഞാൻ പറഞ്ഞു 23 കൊല്ലത്തിനിടയ്ക്ക് 2 കേസേ കിട്ടിയിട്ടുള്ളൂ. എന്നാൽ താലൂക്ക് ഹോസ്പിറ്റൽ വർക്ക് ചെയ്യുമ്പോൾ ഒരു മാസത്തിന് 2-3 കേസ് സ്ഥിരമായി കിട്ടിക്കൊണ്ടിരുന്നതാണ്. സോ ദാറ്റ് ലെപ്രസി എറാഡിക്കേറ്റ് ചെയ്തിട്ടില്ല.
The numbers now. In fact, I was actually because I was a little busy with Dr. Baby Patam's death yesterday. I was telling her I think we should put a slide about the present incidents. We assume that this is not very common because most of us are from the private sector. But it's not that rare. It is still there.
One case we can treat very easily now.
Yeah.
In olden days, leprosy was a stigma because there was no treatment. But now treatment is very easy.
Not only that, sir. See, they are from very well-to-do family, So I was also wondering how will I counsel her about something like this. But she was very pleasant and she was very accepting. I said, though I purposefully, most dermatologists now say Hansen's disease and all that. Kushtarogam എന്നൊക്കെ നമ്മൾ പറയാനായിട്ട് ഇച്ചിരി ഒന്ന് മടിക്കുമല്ലോ because our background is like that. But people took it very positively, in fact.
Thank you for the nice presentation, reminding all of us about something like a re-emerging infections. This is a common topic in most of the conferences now. The other one which is coming back is syphilis. Syphilis is also re-emerging, maybe because we have a lot of migrations and workers coming from all parts of India. That's one of the reasons attributed to be having exotic infections which were thought to be eradicated from this state. Did you work up the husband?
Yeah, he's been worked up. He's negative as such. In fact, so the take-home message was, especially we have a lot of patients who have terribly bad sugars. So when you expect a multibacillary presentation, always keep leprosy also at the back of your mind. So that was our take-home message. There's one more interesting case. I'll hand over the mic to my colleague, Francie Pulikan. Thank you, API, and thank you, Karthik, for the opportunity.